So welcome to everyone to our first National Thrombosis Week Information and Support meeting. We are fortunate tonight to have an amazing panel. We have Dr. Tamara Everington, who is a consultant at the Hampshire Hospitals NHS Foundation Trust and Salisbury NHS Foundation Trust, where she leads NHS care and research development in haemostasis and thrombosis. Along on the panel as well, we have Dawne Archer, who has experienced both DVTs and PEs, and in her own words, counts herself lucky to be alive, having experienced her first events of thrombosis when just 26. However, she is now determined to live life to the full and indulges her love of travel throughout her life. And in fact, Dawn's first book, Trek a Girl Morocco Bound, and I think it's your first book, but I may have an error in that, has not only been a great success, but has shared her adventures and its increased awareness of thrombosis and has even supported Thrombosis UK. So thank you very much, Dawn. And Shaun Kinghorn, who has experienced his first thrombotic event in 2010, when Shaun was admitted into hospital with severe breathlessness and a distinct feeling that he was near to death. Shaun is the Thrombosis UK trustee and is dedicated to raising awareness of VTE, especially the VTE journey for the patient, finding your new normal, and how to navigate life afterwards, which includes managing medical appointments. And on the panel as well, I'm pleased to introduce Annya Stephens-Boal, who many of you may already have met, and she is our fantastic patient support lead and has personal experience of thrombosis too. Just a little bit about managing tonight. So we are welcoming your questions. This is what this evening's about. Thank you for those who have pre-submitted them. Just a gentle reminder that tonight we welcome questions, but we are unable to answer very individual treatment-specific questions that are best taken to your own doctor or medical team. So without any more to do, I'm going to open up and really go to Tamara first, who I thought, just to set the scene, would you be able to just explain why do blood clots occur?
Thanks a lot, Jo, and thanks for this opportunity, and welcome everybody this evening. It's great to see so many people here, actually. I'm a blood doctor. And so what I do is look after people that have had problems with clotting or bleeding. And of course, clotting and bleeding is a part of our normal day-to-day life. We all experience it from time to time. And some of us are born a little bit more clotty, and some of us are born a little bit more bleedy. But during life, we all tend to get an increased tendency towards blood clots. Some of that is under our control and some of it just isn't. So for example, I am blood group B positive. I'm very happy about that because I think it reflects my whole attitude to life. But unfortunately, it means I have a slightly higher risk of blood clots than somebody that is born blood group O positive. Now, somebody that is blood group O positive will probably find that they were the children in the playground that had a few more nosebleeds as a child, or perhaps women that had heavier periods in life. But there's a trade-off in the lower risk of clots later in life. So bleeding and clotting is part of our normal life experience. When we damage our tissues, we get bleeding. That stimulates an activation of our clotting factors and contraction of our blood vessels, and this can result in a blood clot. Now, many blood clots are formed with us not being aware of it at all. It goes on, it's part of our body's normal housekeeping, and the clots can resolve themselves. In the old days, before we had anticoagulation treatment, some people, even with quite severe clots, would get better. But of course, many wouldn't, and many died. And that's why we're fortunate to have a range of anticoagulant medicines available to us today, which has really transformed experience of care. So do we have to treat blood clots? Well, yes, in general, in this day and age, we do treat blood clots. And the problem with blood clots is we know that once you've had one blood clot, you have a higher risk of having a further blood clot. And that's why we start people quite often on long-term therapy with low dose or warfarin anticoagulation in the long term to keep them safe in the longer term, because we can, and because we can help people adjust to a life on anticoagulation well. And by and large, for many people, that is a very acceptable insurance policy for the rest of their lives. So that's just a brief background to why we form blood clots. In terms of how we might diagnose a blood clot, Well, for some people, blood clots may present with no symptoms at all. And of course, that can be a very worrying thing when you're considering that possibility, particularly when you've got family members that have been affected, and even more so if they've had severe blood clots in the past. Most commonly, it's clots in the leg that are asymptomatic, perhaps nothing at all, but more commonly, you might develop pain, swelling, redness or heat in your leg and be unable to put weight through it because it's really uncomfortable. The leg will look different to the other leg. And this is why I always encourage people to just get to know your legs. I've got one leg that's 3 centimeters bigger than the other. I've got one hand that's 3 centimeters bigger than the other. That's just me. That's my baseline. It doesn't mean I've got a blood clot. It's just what I look like. So that's how it is. So know your body, know yourself, and look out for differences. Blood clots on the lung more commonly will present with breathlessness. It's unusual, though not impossible, to have blood clots on the lung without the symptom of breathlessness. And that's the most important. And classically, people think of blood clots on the lungs as being associated with sharp, severe chest pain when you take a deep breath. But actually, it can be a more intense pressure in the center of your chest that just doesn't go away with time. Sometimes people will cough up blood, but that's not an invariable symptom. The one that is invariable tends to be breathlessness. In terms of diagnosing blood clots, we've got various tools to do this, but nowadays the most common thing for diagnosing a clot in the leg is a Doppler ultrasound scan of the leg. So a jelly probe on your leg run up and down to have a look at your veins. Sometimes we find clots in other organs, not just the leg. Sometimes it might be the arm, so we do a Doppler of the arm. Sometimes we find clots in the tummy, so we might do a CT scan of the tummy. And rising up to the chest, the most common way of diagnosing blood clots in the chest would be something called a CT pulmonary angiogram or CTPA scan. Because this is associated with a small amount of radiation, occasionally we use something called perfusion scanning, particularly for pregnant women, where we're worried about the radiation exposure risk. But nowadays, CTPA is our standard approach. And in terms of treatment, I mentioned earlier anticoagulation. Now, anticoagulation is our standard treatment. It's what I call the low and slow approach, which is that our body produces natural anticoagulants anyway, and these are in a dynamic balance. And we add in a chemical anticoagulant on a long-term basis, which just gently shifts the scales in favor of clot dissolving rather than clot forming. In very severe circumstances, we do have to take things the extra mile. And every now and then we will do treatment called thrombolysis, which is clot busting treatment. Or we might, if we have a nasty clot in a leg in particular, do something called catheter-directed thrombolysis, where we target the dissolving thrombolysis treatment to the area of the clot. We prefer not to do this if we can get away with just anticoagulation, because it does carry risks of bleeding. But where people are compromised, for example, people with a blood clot on their lung, where they're severely unwell and they're not able to maintain their blood pressure, we would go ahead with thrombolysis. Or in a leg, if the leg is very compromised and we think it's likely that that could cause long-term effects with the leg, then we might go on and use catheter-directed thrombolysis in that scenario. So that's just a broad overview of all of clotting. And I'll pause for a moment there and hand back to Jo.
That was amazing. I always feel I learn so much when I listen to you. Thank you, Tamara. Dawne, going on from how Tamara's explained, can I go to you and ask, what did you know about blood clots before you were diagnosed, and what symptoms did you have to first make you concerned about what was happening?
Well, I'd certainly never heard of blood clots at all. I was 26 when I had my clots, and I'd never heard of them. And what happened to me was I woke up one morning, bright and early, in intense pain. I was one of those people who had the intense stabbing pain. In fact, I would liken it to how perhaps it must feel to be stabbed in the back. It was excruciatingly painful. I didn't particularly have breathlessness. I had no pains in my legs at all. So that's what took me to the doctor initially. Do you want me to go on and tell you how things developed? Okay, well, I went to the doctor who she went for hepatitis and pneumonia tests, which of course came back negative. I was at home for a week before we called her back in because I was in such a lot of pain. I was just lying on the sofa, really, completely oblivious to what might be happening. When she came in, she was very dismissive. Your tests are negative, just get on with it. Have an aspirin if you're really in pain, and just dismissed the symptoms. I stayed on the sofa for another week. I literally just rolled off the sofa, crawled to the toilet, and then came back again. And at the end of that week, so that's 2 weeks on, my chest had started to rattle, which, you know, is inevitable if you're lying down like that. And that really frightened me. And I took myself off to the doctor and insisted on seeing another doctor in the practice. And it was almost as if they had been discussing me. I think perhaps they had been. He seemed to know who I was and what I was talking about. And in fact, I hardly had to say anything. He rang the hospital straight away. I drove myself to the hospital, absolutely worried sick, obviously, but he told me to drive myself to the hospital, park in a long-term parking space. So I really didn't know what was going on. And in actual fact, it's quite a tale. If you read my book, then you get the long version. But to keep things simple, I staggered into A&E. They were expecting me, and they were marvellous. But I was pretty much on my knees at that point. I could scarcely breathe. It wasn't so much breathlessness, gasping for breath, as just, well, perhaps that's what it is, an inability to take in sufficient air to be able to do what you want to do. And I just kind of staggered in, and a nurse rushed over and put me in a chair in a cubicle. And of course, I had a good old cry at that point, like you do, because I just didn't know what was going on. And they actually kept me in the hospital for 10 days, which this was 1986, so things were very different then. I had no information. Nobody told me what was going on. Heparin on an intravenous drip, and I wasn't allowed to leave the bed. I was on complete bed rest. My feet weren't allowed to touch the floor for 10 days, which of course is completely contrary to current advice. But that's how they did it then. I was put on warfarin for 6 months with dire warnings from a most unsympathetic doctor. And off I went home, still in pain. And I think that's something that perhaps people come to Annya quite often. You know, they've been diagnosed, they've been put on anticoagulants. Why am I still in pain? And I didn't understand that. I understand it now. Because having a clot causes bruising, causes damage, and it can take quite a few months for that to ease up. But yeah, I had no one to go to. I had to go to the warfarin clinic every week, but it was lots and lots of old people and me. So nobody had any advice that was age appropriate. And I just got on with it, really. I didn't even have any advice on diet or how I should be living. So I just barged on as normal, really. For 6 months, I had 6 months treatment, and then I was just cast adrift and merrily got on with my life, completely oblivious to the fact that there was something in the background. It wasn't until 2001, and my dad got a blood clot, and he got a DVT, and it didn't clear. In fact, it was interesting just hearing about thrombolysis, because I don't know if it was available then, perhaps not. That might have helped him because the clot didn't disperse, and in actual fact, it stopped the flow of blood to his one of his feet, and that's when we knew we were in trouble, because his foot went black. And so off he went to the hospital. My dad died of a blood clot in his lung. A piece of that one in his leg went to his lung. at that point, I started to ask questions, and then it became evident that in his side of the family, there were frequent episodes of unexplained early death, sudden death. And I then learned that his mother had had a clot in childbirth, and his younger brother died at 30 very suddenly. So it's all there in the background. But at that point, I started to ask more questions. And keeping the story short again, there was lots along the way, but I've since been diagnosed with Factor V Leiden, which is quite common, but I'm homozygous, so I've inherited that from both parents. And what people are often quite interested in is to hear that my mother's 86, fit as a flea, has never had a clot. But I lost my father to it. So that's where I'm at. I am on lifetime anticoagulation, but that has only been the case in the last 2 or 3 years. So I've got to almost to 60 without having permanent anticoagulation. So that's me.
Thank you. So many questions arise from that. And I can see in the chat, actually, some questions are coming through link, which I know I will go to Tamara with in a moment. But I just want to go across to Shaun, because Shaun, you had your clot 10, 12 years later than Dawne. Was your experiences different? Obviously, symptoms could be the same, but from what you understood or knew about blood clots, and then your experience of actually having one.
Yeah, thanks, Jo, and thanks, Dawne. Some of Dawne's experiences resonate with me, but I guess our backgrounds are quite different. And can I say, first of all, I was a nurse, practiced a nurse before I had the PE, and I didn't recognise I'd had a pulmonary embolism. So I'm not going to, which is quite interesting. I've looked after people with pulmonary embolism, but I did not recognise it in me. And my wife was an A&E nurse. But by way of, I guess, a thumbnail sketch, at age 49, it was a total shock for me to have a bilateral pulmonary embolism. And it was confirmed that was unprovoked, no known cause, no long haul flights, no long train journeys, and nothing like that. And I had 30-year history of running marathons, cycling 150 mile a week before the clots. And how I found out where the pulmonary embolism was going to, obviously in its early stages, is I'd swim before work 80 lengths. I'd swim a mile 4 times a week. And one morning I went in the pool and I couldn't swim. I was too breathless. So I just went to work. I felt okay after half an hour, went to work, made an appointment with my GP. GP did an ECG, which was clear, but a chest x-ray showed that my left diaphragm was paralyzed. And he referred me on to a specialist, a respiratory specialist who specialized in lung conditions. And I got an appointment for 3 weeks later. Well, approximately 2 weeks after that visit the GP, I didn't get to visit the respiratory consultant. I basically was at home and suddenly felt absolutely ghastly. And it resonates with what Dawne was saying about the breathlessness. It's almost as if my body was dictating how I should breathe. I'd lost total control. It was doing its own thing. And I looked in the mirror and I was grey and my lips were blue and I felt shaky. And I said to my wife, I'm going to have to go to the hospital. I think I'm going to die. And the feeling was just so strong. So we literally were 2 minutes away from A&E. I managed to get in the car, was taken straight into resuscitation. And they did all sorts of blood tests, etc. And the blood test shows I was tipping into respiratory failure. My lungs were not able to work sufficiently to get me sufficient oxygen, so they gave me 100% oxygen. And to be honest, the rest of the day was a blur. Apparently I was confused. Staff came to see us, and I can't remember. I remember my family visiting twice, but my eyesight was blurred. I felt really, really unwell. But it could I guess move forward a little bit. Ultimately, after having anticoagulation injections, they contemplated giving me thrombolysis. I was sitting on the fence in terms of whether it was the right decision or not. I was discharged home after 9 days, but admitted 2 weeks later with a query extension of the clots. And also it was another 6 weeks later, I was readmitted again. I was struggling. And my progress was incredibly slow. Here was somebody who could swim 88 lengths, you know, and 2 months later was still struggling to walk 200 yards without getting profoundly breathlessness. And it was an incredibly difficult time. Ultimately, I was referred on to a pulmonary hypertension specialist who diagnosed with a heart catheter test, where they put a tube in through a major blood vessel and checked the pressures inside my pulmonary blood vessels, showed that I had elevated pressures still after a year. And my lung function tests after 2 years showed that I still wasn't exchanging gases properly, but was not diagnosed with that scary complication of chronic clots in the lungs. But can I say, like Dawne, ultimately, when I got through that phase, I was so grateful for what I had. And now I'm actually back running. I've done 166 park runs, paddleboard off the northeast coast, and I've walked up Skiddaw. But I'll tell you, walking up the side of Skiddaw, it took me a long time to go up Carl's side. But I'm at the stage now where breathlessness on exertion is part of life. I just accept it's part of me now. Fortunately, I have had no more clots. I'm on lifelong warfarin and self-test at home, thanks to the support of the Thrombosis UK team. So that in a nutshell is my background. Really, really hard first few years though, Jo.
Thank you so much, Shauna, and to Dawne. And you both raised something that I know Tamara touched upon, and to come back to you tomorrow, and I know Annya hears this a lot as well. Despite being nurse trained, despite going to very highly qualified and experienced doctors and nurses, it can be very, very difficult to recognise that this might be a blood clot, or for individuals to think or notice the changes. Is there anything that we should be alert for to help? Because obviously getting that early diagnosis can prevent catastrophic harm or worse as well. So it's so important.
Yeah, I mean, I just need to say, really moving stories. This is a devastating condition with life-changing effects, and I never underestimate the impact of that. So thank you so much, Dawne and Shaun, for sharing your stories there, and the people in the chat as well. So it's difficult, I think, is the answer. I always encourage people to be clot aware. I don't think we always do people favors with this focusing on aeroplane flights business. In my mind, being on a flight, it's not a lot. I mean, a lot of people get swollen ankles on flights because of the pressure changes, but it's not very different to being on a long journey or sitting cross-legged gaming or, long coach journey. But the people have got a bit obsessed with it and think, oh, well, I haven't been on a flight, so I must be fine. And they're not thinking about the breadth of their risks, which is, where one, I mean, of course, in Shaun's case, out of the blue. So that is very, very difficult. I try and encourage people where there is a story in families to make sure that every member of their family and their friends as well is kind of clot aware, because if in doubt, ask for help. Ask for help. We can do some tests. We can do a screening test with a D-dimer, which isn't very useful if it's positive, but if it's negative, then it's pretty good at ruling out a blood clot. And I always say I'd much rather people ask for help and we ruled out the diagnosis than the other way. The other thing, of course, in this day and age, which has changed, is that following COVID, a lot of people have got oxygen saturation monitors, finger probes at home. And that's actually quite useful. And that's particularly useful, I find, when people, maybe have had anticoagulation, but choose to stop it. But they're still feeling very breathless, and perhaps we can come back to that separately. They're still feeling very breathless from time to time, and they want to know, could it be another clot again? And having that finger probe test relatively easily available to you can be quite a good way of quickly checking your oxygen levels to see whether or not they've dropped. And that could be related to your breathlessness.
Thank you. And something again that both Shaun and Dawne mentioned was the risk, and in your talk, the risk of recurrent clots and not being aware of this. So is everybody at risk of another clot after having a clot, or is it greater in certain circumstances? Where do we, how do we know about this?
Yeah, so when I was training, we were all, we're going to anticoagulate for 3 months, 6 months, stop. And it wasn't great because at that time as well, we were using perhaps a combination of old-fashioned heparin with warfarin. And quite often in the first few months of treatment, people weren't optimally anticoagulated for that reason. It's quite different now in this age of low molecular weight heparin and DOACs. So people get better anticoagulation from the off. But so they not only didn't get very good anticoagulation initially, but then we'd take them off anticoagulation after 3 or 6 months, and we'd say arbitrarily it was provoked or it was unprovoked. I find that for myself is actually often a really, really difficult call to say, was it provoked or was it unprovoked? As far as I'm concerned, if you get a DVT from a flight, that is unprovoked, because most people that go on a flight don't get a DVT. Nowadays, even if you get a DVT after hip replacement surgery, to what extent is that provoked? Because most people that have hip replacement surgery don't get a blood clot. So you have to say, getting a blood clot in the first place is telling us something about either the way you were born or the way your clotting system has matured that is predicting for future risk. And if we look at the statistics on risk, the longer you live, the more, unfortunately, the more likely it is you go on to have another blood clot. And that risk, if you live a long life, can be more than a third, to be honest. As I said, the risk is a bit lower with provocation, but the reality nowadays is that we're looking at a long-term treatment option for most people with a severe clot.
Thank you. Sorry, I talk without my mic on. Can I just return more to Annya as well as to Dawne and Shaun? You've mentioned, I know, Annya, also, you received calls about this, about the pain. So you're diagnosed, thank goodness, you know, or you've been told what it is, and you're given anticoagulation normally, and maybe other treatments if it's required, but the pain can continue. Dawne and Shaun, I know you both mentioned this. How long did that pain continue for, Shaun?
To be honest, Jo, I didn't have any pain at all, which is quite interesting. I did have pain 4 months later, quite severe pain, which is strange. It was around the outer edge of one of the lungs. It really kept us awake. But at time of diagnosis, subsequent treatment, I didn't present with chest pain. And I think that's why I didn't hook in the fact that I had a pulmonary embolism, because my understanding at that time was you normally have chest pain, you know, of some kind. But no, it wasn't an issue for me. I'm glad. Dawne, maybe you got the short straw.
Yes, it sounds like it. Yeah, I had pain, quite severe pain. It didn't diminish very much in the hospital. So the severe pain was still there when I left hospital, and it gradually diminished, but it took about 6 months, 6 or 7 months before really I could say that there was no pain on taking a deep breath. But I didn't really get what I would call breathlessness, which is what Shaun experienced.
Yeah, why does this pain occur, and what is there anything we can do to reduce that, or is there anything that can be helpful to understand what's natural or normal, and when to present in hospital or to your doctor to say, I'm still in pain, I'm worried something is still wrong?
Yeah. So one of my frustrations is that people are often led to believe that this is going to be like a course of antibiotics and they're going to feel better very rapidly. Now, for some people, that is the case, but not for most, unfortunately. For about 3/4 of people that have a PE, you know, they have longer term symptoms of breathlessness. And that's a mixture of different factors. Some of it is about the clot resolution or not. A small proportion of people, unfortunately, don't get full resolution of the clots, and they're left with chronic pulmonary thromboembolic disease, and some even require surgery for that in a small proportion. In some people with significant clots, it's caused a change in the pressures within the heart, that cause a long-term effect on the heart. So the heart function is not what it used to be. In other people, there's some interesting things that goes on. There's some of it is about healing, I think, and I often find that people that have clots right at the edge of their lungs have pain for an awful lot longer than actually the central ones. And I think it's about the scar tissue rubbing when you take a deep breath in the long term and tweaking and giving you ongoing pain there. And I usually find that eventually settles down over a few years. And the rule of thumb is if it's getting better all the time, then that's sort of reassuring. And then there is another whole group of people who, and I actually have a psychologist in my service. And now we've actually got a team of psychologists, because something quite unusual sort of happens once you've experienced something as traumatic as this, in that your brain becomes hyper alert, hyper aware of the symptom of breathlessness. Mm-hmm. And so when you feel breathless from having gone upstairs in years gone by, you might have your brain might have felt okay with that, but now your brain doesn't like that at all. It's screaming at you, you're at risk, you're at risk, you're at risk. And then you breathe, you can hyperventilate, and things can get much worse in that situation. So the symptoms tend to sort of propagate themselves. And that's not an easy thing to get through, because sometimes I also get a bit frustrated when people say, oh, be heroic, battle it through, da, 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 da. This isn't a battle. It's and your brain takes time to come to terms with this symptom and recover. The other thing that can happen, of course, is that you can lose condition. You can lose condition as well as confidence. So you stop pressing yourself in the same way that you might have felt able to do before. You feel uncertain about getting back on an exercise program. And so you just generally lose condition and fitness. And of course, this is a problem for me at my age of life, not taking the exercise I want, and it's much harder to get it back at that point.
Is that somebody called Lynn has also asked it? She suffers with joint pain, and I know Annya has heard from others like this. Are there any particular anticoagulants that might be better interacting with other medications to reduce joint pain, or are they all very similar, or anything like that?
So that's a tricky one. I mean, so I just go back a step actually and think about why we get blood clots. So people have talked about protein C deficiency, protein S deficiency, antithrombin deficiency. So that's a deficiency of a natural anticoagulant. And factor V Leiden is where you are relatively resistant to the protective effects of the natural anticoagulant protein C. So it's all about an anticoagulant deficiency. And then there's the prothrombin gene mutation, which is where you've got a sort of pro-coagulant sort of dominance going on there. So it's kind of about getting the right balance in life. And this is where I think it's important to recognize the importance of balance in life. So there is a reason that we have this boring mantra about 8 hours sleep at night and eating lots of vegetables in the day and drinking lots of water. It's because that is the best way to maintain good health. And I'm as guilty as the next person in not always sticking to that. But the truth is that sometimes when our joints ache, when we're not sleeping well, when we've got headaches, when we're feeling chronically tired, it's because actually we're not always looking after ourselves as well as we might. So it's just a sort of reminder. There's no doubt at all that less than 8 hours sleep is associated with an increased risk of thrombosis. The risk increases the day the clocks change. More people have heart attacks, strokes, and blood clots the next day. It's really, really quite a stunning thing, that. So in terms of which anticoagulant is best, I'm not sure I know the answer to that. To be honest, in this day and age, if I had the choice of a DOAC, I definitely would. It is so much more convenient than warfarin. And yes, I agree with the person in the chat who said self-test. Absolutely, self-testing is really good. It's often helpful to work with an anticoagulant service to help guide you on dosing if your control is a little bit variable. But nowadays, most people can go on a DOAC. As you will know, there was one trial that looked at people with very high risk antiphospholipid syndrome and said that in that group, warfarin was The trial was stopped early because warfarin was superior in terms of preventing arterial events than rivaroxaban. And on the basis of that trial, the DOAC manufacturers all withdrew from supporting treatment in antiphospholipid syndrome. But around the country, most hematologists nowadays would give people that didn't have very strong antiphospholipid syndrome with arterial thrombosis. If it was venous thrombosis and positive lupus anticoagulant, they would offer them a DOAC. And I don't know whether it's different in joint pain. I think all anticoagulants to some extent contribute to osteoporosis risk. And certainly the low molecular weight heparins do as well. So that may be a factor, but I'm not sure about the joint pain itself.
I am sorry to target so many questions to you, but I know another question was pre-submitted, and I know this one is very much for you. It was really a question about whether there is any thoughts on the use of medical cannabis for pain relief in patients on DOACs who can't take anti-inflammatories and pain control in general. So whether there's any guidance on this or any evidence to support this.
So I don't really know about DOACs, but the one thing I would say about anti-inflammatories is that I think we've rather oversold this story. So I look after a lot of people with haemophilia, and a lot of them unfortunately have chronic damage to their joints. And in this country, we tend to use a particular type of anti-inflammatories, but in the rest of the world, people use ibuprofen on a regular basis to support people with horrible incapacitating joint pain. The important thing about the anti-inflammatories is not so much the bleeding risk, because actually high dose anti-inflammatories are associated with an increased stroke risk. It's not so much that, it's if they upset your stomach. So what we can't afford is for people to get stomach ulcers, because obviously that combined with an anticoagulant is a disastrous combination. So I would go back, and very much with my rheumatoid arthritis patients, not having an anti-inflammatory is just not an option. So we just have to find the right thing for them and the right wraparound package to support them. What do I think about cannabis oil? Don't know enough about it, to be very honest.
Fine, thank you very much. Annya, coming to you, because I haven't had a chance to talk with you yet. You hear from so many people every day. One way they're talking about treatment, and we've touched upon it at the moment, but what do you find as the sort of most frequently asked questions and issues around anticoagulation treatment for people diagnosed with thrombosis, the worries and the concerns around this?
Well, I think there's a lot of them, but there are themes that come up frequently. And funny enough, we've just touched on one where a lot of people complain that they have pain, and either they're not taken seriously often by their GPs because they've been diagnosed, prescribed, and then they're sent back to their GP, and their GP's just sort of going, well, it's a bit of pain, you'll get over it, Then, of course, they go and they talk to Dr. Google and they start reading all these awful things about you can't take this and you can't take that and you can't take the other. They go back to their GPs still in chronic pain, and just seem to be beating their head against a brick wall because the GP is saying, well, just take some paracetamol. Well, paracetamol doesn't touch it. Well, you can't take this and you can't take that. So my advice to them is usually to go back to the GP and either challenge the GP to get their pain control better, or refer them onto a pain team who have got better knowledge of what can be used with what drugs and what are contraindicated in certain cases, and get the pain under control. But I think a lot of them, they're just really frustrated that nobody really seems to be taking them seriously. And my clot was 40 years ago this year, my anniversary, my PE. And if I've got something like at the moment, I've had a viral infection and I've got post-viral lungs, I'm coughing away like a drain, but I also get the pain right here, right where it was. And even after 40 years, and even though I've got a very sensible head on, I still occasionally sort of go, could it be? Especially as I haven't had one for so long. And that's something else that comes up, is the hypervigilance, and every last little twinge and pain will start people off, and they tend to start getting very tunnel vision and focusing on a pain, either in their leg or in their lung, or I've been talking to a lady recently, and it's CVST, and it's actually quite a rare clot, but now every single time she gets any sort of pain in her head whatsoever, she's absolutely terrified that she's going to get another clot, or the clot that's in there has done something and is moving around or whatever, and terrible anxiety. That's something else that comes up a lot. And another theme that's forever coming up is people just going in, having their scan, being diagnosed. Here's your rivaroxaban or your apixaban or whatever they've been given. Go home, send you back to your GP, and they don't have any follow-up at the hospital at all. And they often end up going to the GP. The GP has little to no knowledge of thrombosis, much less all the little complications and little idiosyncrasies that come along with an awful lot of clots. And they just feel that they've been, basically, as Shaun said, just left to go adrift, and that's when they come to us, because they're just so desperate for some sort of support, and nobody's supporting them.
I was just checking this out. And so, looking at that, what sort of information is available that individuals, and what range of information is available?
Oh, well, we have an incredible website. I must say, I am so proud of our website. I think I must get compliments every week, even though it's nothing to do with me. I receive them, and it's wonderful about how great the website is. And a lot of people who phone up, they've got our number from the website. They found the website, they've got information there, and they just want a bit more padding on what they've read, or they perhaps don't really understand what they've read. We've got everything from information leaflets to videos, if people prefer, podcasts, presentations, an amazing psychological section, which is expanding all the time, with lots of self-help resources. I often point people there if they're having trouble sleeping, or they're very hypervigilant, as Tamara as mentioned. A lot of people are. We've also got the helpline, of course. That's Monday to Thursday, 10 till 4. You'll either get me or you'll get Joe on a Monday, because I don't work on a Monday. I'm quite happy to talk to anybody about anything. There's no such thing as a stupid question. There's no such thing as people saying, well, I know I don't want to be bothering you. Believe me, you're not bothering us. That's what we're here for. And then, of course, we're now starting to develop one-to-one support. I've now changed my role very slightly, and I've gone back to doing patient support. So you can now get one-to-one support from me by email, by phone. You can even Zoom with me if you want to just sit and have a little chit chat with me. It's all non-medical, I'm afraid, but I can signpost you to resources that can explain medical things that I can't explain to you, because I'm not a medic. But I am a grade 1 counsellor, so I can provide very basic counselling. I can also give people a lot of advice on self-help. So we have massives, and there are plans in the pipeline, hopefully this year, to start the coffee and chats again. We used to have coffee and chats online. I used to run a mindfulness group in the middle of COVID, when everybody was just so scared because of the connection between clotting and people who'd already had DVTs. And I'm also, at the end of June, I will become a qualified clinical hypnotherapist, and there is a possibility that I might be starting to offer some sort of anti-anxiety hypnosis, either in groups or as one-to-one. So there is a lot coming this year.
Thank you. That's amazing. We have a question from Anne about how do you get to self-test? Now, Shaun, you have a story on this, don't you? But I wonder if you could help here, because Annya will agree as well. Across the UK, this varies considerably. But Shaun, I hope you've had this journey. So how did you manage it, and what were the benefits in the end for you? And obviously this is for people who are prescribed warfarin, who possibly either are unable to take an alternative anticoagulant, or who perhaps prefer to take warfarin. Shaun.
I think the first where it started was, I think it was a point in my recovery journey where life was getting back to a new normal, and anticoagulation, I wanted to make that part of it. And the first thing is I need to find out, do I really need to go into self-testing? Because for the first 5 years, I felt really reassured having a pharmacist there to deal with me queries and so forth. So I got that level of confidence, and I tried for 4 years, and some healthcare professionals actually said to us, it's not safe for you to self-test. I went to a pharmacy, community pharmacist recommended me GP. She says, no, you shouldn't be self-testing. It's not safe. But I then started to look at the literature and speak to colleagues at Thrombosis UK. And we're talking about the evidence around that, and so forth. So basically, I went to Thrombosis UK and said, where do I start? How do I go about the process of starting self-testing? And basically, they coached me through the process in terms of looking at different options, what questions to ask. And so I went back to my GP, and my GP actually went to another GP in the practice, and they were really supportive and applauded the action of self-testing. So there's a variance here between healthcare professionals, but my supportive GP and actually was then right into the clinic, and the clinic were reticent about switching over. But now I've been doing it now for 14 months. And can I say my INR control is much better. And it's lovely. I'm going to see my son. I'm with my wife. I just take my machine with us, and I know I'm going to get a call. And so the quality of my life has changed just because I feel empowered. I think it's also the process of understanding, which is just as much as important of getting to that point where you are self-testing as a badge of honor. It's a process which is empowering, really.
Thank you, Shaun. That's really positive. And it's really good to hear a positive account of support from your GP or a GP as well. Thank you. Tamara, is self-testing, obviously for warfarin, suitable for everybody? And it varies across the country. When is it worth considering, perhaps?
Yeah. So you do it. Somebody pointed out in the chat. When you've got a lupus anticoagulant, particularly if it's very powerful, it can affect your baseline INR, and so it can make it slightly problematic doing INR testing. We can often find ways around that, but that can be an issue. There may be other people that, for one reason or another, don't have a normal baseline INR. Perhaps they have liver disease or something like that. Again, that can make it a little bit tricky. But by and large, self-testing, I think, is really positive. The difficulty we still have at the moment is that people have to buy their own testing machine, and that's usually about 300 quid. But a lot of GPs now will prescribe the strips, which are sort of £1 a day, so they are an expensive bit of it. But I think it does give you a lot of versatility and control, and particularly for people that are out and about, a lot, or traveling. I think it's a much better idea. An interesting thing to sort of inject here is that, so we did a research study testing people on rivaroxaban and warfarin, and what their lived experience was of anticoagulation. And it's very interesting that people have very strong beliefs related to their anticoagulation. And for some people, being in control is very, very important. And if you try and change them from warfarin, they actually become very unhappy and worried because they feel safer on warfarin. So it's not entirely straightforward. The mechanism of anticoagulation is slightly different. I sort of explain warfarin as a bit of a dripping tap. So think of your pipes blocked and it's a sort of dripping tap to keep them open, whereas a DOAC is more of a turn the tap on fast once or twice a day, pulse the system, and then it goes up and down again, which is why testing isn't very useful by and large, because you haven't got that sort of continuous effect.
Thank you. That's really helpful, answering a question that I could see it arrive. Thank you. Dawne had mentioned that obviously she didn't know that she had factor V Leiden, and then so continued for probably about another 40 years not on anticoagulation. If you are prescribed long-term anticoagulation, are there any times when you might be considered, or you could have a conversation about coming off it, or the risk factors? Or is it, on balance, the evidence is there that you are much safer on an anticoagulant? Because certainly this arose a lot during COVID pandemic, when we had a lot of very understandably very worried people who had suffered clots and now were incredibly worried about COVID and clots. And one possible benefit we could say was, obviously the clots occurred in severely ill or people who were severely ill with COVID pneumonia, and also already being on an anticoagulant to manage their thrombotic risk was possibly a benefit to them as well. So in general, if you're prescribed it as a lifer, as many people here have mentioned, what are the benefits of that?
Yes, I mean, COVID and thrombosis is a whole other story, isn't it? We've learned a lot during this time. It's been very hard. As a lifer, so the difficulty is with thrombophilia tests is that even in families where there's a really strong family history of thrombosis, they'll only test positive on thrombophilia screening in about 50% of cases. That means we're missing a lot. Now, we have got better, and we have got a thrombogenomics panel now, and there is whole genome sequencing, which is going to give us even more information there. But so that kind of tells you that a negative thrombophilia test isn't actually incredibly reassuring in the presence of a strong family history. And equally, the other end of the spectrum, of course, 5% of the normal population are heterozygous for factor V Leiden, not homozygous like Dawne, but heterozygous. So simply having that, you could be a person with haemophilia, bleeding tendency with factor V Leiden. So that way around as well, it's not that helpful or reassuring. The tests that really make a difference are knowing that somebody has antiphospholipid syndrome. That's a must do for anticoagulation. And the other test that's quite useful is a D-dimer if you're off anticoagulation, because if that is chronically elevated, you have got a higher risk of having further clots. I always talk to people about insurance policies, relative insurance policies. Most people can be on a low dose DOAC in the longer term. And for people that have had a DVT in the leg, there's quite good evidence that low dose aspirin can reduce your risk of recurrence by a third. And that can feel quite a bit more acceptable because it's a non-prescription medicine. It can help protect from heart attack, stroke, and even colon cancer. So it depends on your experience of anticoagulation and what your risk appetite is. The most important thing is to find something that works for you, that keeps you physically safe and makes you feel emotionally safe as well.
And I guess also the message on that is it's really important to have that one-to-one conversation with your doctor, isn't it?
Yeah, very.
And they know you as your risk, your everything, your life. Thank you. I can see a question come in around having had a thrombotic event and then you reach menopause and you're thinking about going on to HRT. There's been a lot in the news on this. We've actually also got some films and some information sheets on the website. But HRT and thrombosis, do they go together? Can they go together? Over to you, Tamara.
Yeah, so, well, the first thing is that transdermal HRT isn't really a risk. So that's okay. And actually, if you're staying on anticoagulants anyway, I'm pretty generous with HRT, if that's what you need to keep you in the right balance. The problem comes particularly if you've had an estrogen-provoked clot and you're not on anticoagulation and transdermal HRT isn't cutting it for you. That is a bit of a discussion. I mean, HRT isn't as high a risk as pregnancy or the combined pill, so it's a relative thing. So you can weigh up the balance there, but that is a little bit of a caution. The other thing I've just seen come in is this once daily, twice daily DOAC. Now, intuitively, you might think that a twice daily DOAC is superior, but the clinical trial evidence doesn't show that. It doesn't, which is kind of interesting. And I suppose a parallel to that is we take medicines for blood pressure once a day. Do they last 24 hours? No, they don't. So we don't entirely understand how the body works, why a once a day treatment can be all right in terms of keeping you safe. In terms of what time of day to take it, if you want to lead a really active lifestyle, I always say to my patients, if you want to do bonkers stuff like downhill skiing, whatever, this crazy stuff, active life you want to live, take it at night, because the peak level is 2 to 3 hours after you take it. So you'll be heavily anticoagulated overnight. And then in the day, if you manage to pile up on the ski slopes, then you'll have a relatively lower risk of bleeding.
Okay, thank you. And actually, again, you've highlighted the importance of knowing your body and working to what suits you best because you return to life. Now, we are almost out of time, but I think on those themes, I'd really like to go to each of the panel members, starting with Dawne, if you don't mind, Dawne, about having had a thrombotic event and then obviously tragically losing your father and realizing that you had factor V Leiden that put you more at risk. what are the positives that you've been able to build in your life despite this, and that you would like to have as a message to others? Because thankfully for lots of people, there is a life after blood clots, but it's sometimes very hard and it's got to be persevered to find. What would you add as your advice?
Well, exactly that. It is hard to find. It can be very hard to find your way forwards after a thrombosis. But I always think of one thing. For me, knowledge is power. So the more I can find out, the more information is out there, I feel that gives me power. And for me, I have decided that I can take some measure of control by keeping my weight steady, eating well, keeping fit, being, getting out there, having a walk, whatever it is, being conscious of not sitting for too long, keeping hydrated, all those things. If I do those things, I feel that I'm exercising power over my situation. But I have to say, just going back to what you were saying before about the DOACs, for me, apixaban is a revelation. I could not live the life that I do. As you know, and perhaps some other people do, I like to travel. I like to have quite a lot of adventures, and I could not do that on warfarin. I simply couldn't manage it. So, life-changing.
Thank you. Shaun, to you. Now, you were such an athlete, and as you explained, for a long time, you struggled to do the basics, but you have achieved so much since, from running, from taking part in fundraising for Thrombosis UK, and climbing so much more than I do. What helped you along that journey?
I think first of all was to actually challenge myself, because I think one of the things is that I noticed that I'd say to myself, I'll never be able to run again. I mean, I once seen our two daughters run, and my wife said, is that the case? And I never thought about that way. I just never want to be breathless. But what I do is, from then, I'd actually ask healthcare professionals, what do you think? What are the risks? So I got a support team around us and asked them, and then they helped me reach my potential again. And I think that's the first thing I've learned, is that I could do a lot more than I thought I could in my early years of diagnosis. And I notice Anthony makes a point about exercise and so forth. Also, it's about listening to my body. My body will tell me whether I can do something or not. My exercise tolerance, I can't do marathons anymore. My heart rate goes up. I start to get tired after about 50 minutes. So I learned to accept that. So I think the first thing is we can do more than we think. And secondly, that exercise and keeping well again, as Tamara and Dawne have alluded to, was allowed to me to have surgery and get over other issues that come in the longer term, because we are going to be exposed to more care and treatment. So my thinking is, if I can actually place myself in the best position possible to actually have those choices, then I can contribute to my safety and not place that burden totally on the healthcare professionals. Last year, I was diagnosed with bladder cancer and was successfully treated. It took a bit more time to recover, but the anaesthetist says, you're the man with the impressive VO2 max. I said, thank you. I have never had that compliment before. And that was testament to the healthcare professionals that helped me get back to a better place. So stick with it. It gets better.
Thank you, Shaun. That makes me very emotional, but just in awe of all of you. Annya, you hear from many people and you have your own personal experience as well. What have you found as a patient support lead in Thrombosis UK that many people will benefit from after suffering from a thrombotic event or more?
I've just had a frantic little scribble here. And 4 points, really. Don't ever be afraid to ask for help. If you need it, ask for it. It's here. No question is ever a silly question. I get an awful lot of people saying, I think this is a silly question. There's no such thing as a silly question. So ask it. Don't be afraid to try something new. Don't think, oh, that sounds a bit woo-woo or a bit outside the box. Have a go at it. It might just work for you. And I think most importantly, if you have permanent changes because of your clots, as I have and as many other people have, try and learn to love the new you. Try not to spend too much time back with that person, because that person's gone now. They're back there. You are standing here now, and try to make the best of what you have, and just try and learn to love what you still have, because there are many, many people out there, my mum, Dawn's dad, that aren't here now. And, you know, my mum died when she was 59. I'm now 63. And I thank God every single day for that extra day I've had that my mum never got. She never had that opportunity. So I just love who I am now. And I don't think back to those times when I could cross country run and do this, that and the other, because that was then and this is now. So yeah, those are my 4 points to take away from this.
Brilliant. I'm going to cry soon. Tamara, Shaun said, well, you know, we look to our doctors for support and guidance. What are your tips for people recovering from blood clots and wanting to reduce their risk in the future, but actually recover to live well?
Yeah, there's no easy answer to that. Annya is an amazing resource, clearly. I think, you know, don't regard this as a battle. You know, if you're frightened and worried, that's an important emotion to understand, and you need to work with it to try and come to some acceptance of that. You know, it's really frightening, and that does tend to get better with time, and reaching out and getting help and support from people around you is really good. The other thing I would say is that just because something is good for you today doesn't mean to say it will be good tomorrow. There isn't enough annual anticoagulant review happening. And this is really important because our bodies change. Other things happen. Like Shaun said, he got bladder cancer. You know, other things happen. You know, maybe our kidneys don't work so well. Maybe we become more frail. And so what was right for us then isn't so right for us anymore. If you might get started on new medication, for example, and it might be that the combination isn't quite right. Is it your rivaroxaban didn't work because you were on an interacting medication? You know, so it's always good to keep touching base on an annual basis is a sort of rule of thumb, but it's when you touch base with your doctor, say, you know, is this still right for me? Should I be doing this? Is there something different? Is there something new? There are some new anticoagulants coming out related to factor 11. So you never know, we might have even better stuff in the future.
Thank you so much. That has been inspiring and so informative as well. And I think we can all see from the chats and from the questions how much everybody attending has appreciated and benefited from this. So thank you all so much for your time and your generosity of sharing your knowledge and your experience. Thank you to the audience, and this recording will be available shortly. We look forward, hopefully, to seeing many of you on Thursday in our next session, which is regaining activity after blood clots. So for now, thank you so much. Bye-bye.